Hi, good afternoon. My name is Mona Shah. I'm a Senior Program Officer at the Robert Wood Johnson Foundation. Thank you for inviting me to this presentation. Next slide. At the Robert Wood Johnson Foundation, we are working alongside others to build a national culture of health that provides everyone in America a fair and just opportunity for health and well-being. For us, equity is front and center of all our work. Health equity requires removing obstacles to health, such as poverty, discrimination, lack of access to good jobs with fair pay, lack of access to healthy foods, and lack of access to health care. Next slide. We took this approach because research and data showed that we wouldn't make progress unless we dealt with the history, structures, and systems that perpetuate these inequities. Take, for example, research from the Virginia Commonwealth University that people living just a few blocks apart have vastly different opportunities to live a long life, in part because of their neighborhood and conditions of their neighborhood. Take, for example, the community that Robert Wood Johnson Foundation is located. While a person born in Princeton can expect to live 87 years, our neighbors in Trenton, New Jersey have a life expectancy of 73 years, a staggering 14 years age gap across only a dozen miles. And we see this disparity across the country. In Atlanta, for example, life expectancy can differ as much as 12 years between the Buckhead and Northwestern communities. In Chicago, life expectancy can differ by as much as 16 years between the 7 L stops that separate the Loop and Washington Park. Next slide. Furthermore, we know the pandemic has made things even harder. Researchers estimate that during the pandemic, food insecurity rates doubled nationally and tripled in households with children. The relationship between COVID-19 and food insecurity is bidirectional. Food insecurity is associated with increased risk and poor control of chronic diseases, which consistently have been shown to put individuals with COVID-19 infection with higher risks of complication and death. As with the COVID-19 infection, the burden of food insecurity falls disproportionately in low-income and Indigenous, Black, Native Hawaiian, and Pacific Islander and Latino communities. On this graph, you see the high rates of hunger and insecurity during COVID-19 pandemic. 4 in 10 Black and Latino families are dealing with hunger and food access issues over the last year. And even before the epidemic, people of color and low-income communities suffered from access to healthy foods. Access to healthy foods is further restricted by food deserts, which are neighborhoods without grocery stores, and food swamps, which are neighborhoods saturated with fast foods. Next slide. The reason for this is that policies have been stacked the deck towards our unhealthy food system. Take, for example, food deserts, where there's lack of groceries in the neighborhood. We know redlining had an impact on shaping our current food system. Insurance companies labeled businesses in Black communities as high risk. So not only did that impact housing, but also grocers, restaurants, and other businesses' ability to operate in those areas. Today, many of those same redline neighborhoods are where accessing healthy food is a challenge. So in this map you see here, homeowners, it's a map of the Homeowners Loan Corporation map of Atlanta in 1938 and superimposed with locations of supermarkets in yellow and convenience stores in orange. So as you can see, the areas that are redlined, there's a lack of supermarkets, but an increase in convenience stores. So what can we do and what do we need to do? Next slide, please. What we need is public policy and health systems to respond, and we know what works. This has been well studied and backed up by solid evidence. There are serious questions that Americans are asking themselves every day. Do I get medicine or do I need to buy food? Do I pay the electric bill or do I buy food? We need to look at those systems currently in place and make sure they're working for the most vulnerable during the pandemic and beyond. Public assistance programs like WIC, SNAP, and school lunches are needed to be fully funded. And we need to make it easier to use by allowing things like extending enrollment to more than 1 year, online purchasing, providing higher allowances, so people are not making the decisions between food or medicine. We also know healthcare systems have a huge role. Health insurance should allow doctors to just prescribe vegetables and fruits. We know that these food prescription programs have worked. A recent CDC study has said every visit under a food prescription program within a 4 to 6 month period has resulted in greater consumption by children and their families. We also know, based on science, that nutritional interventions can prevent and improve and even reverse chronic diseases such as obesity, diabetes, high blood pressure, and heart disease. Diet is one of the most important modifiable risk factors of chronic non-communicable diseases, is why, simply put, food is medicine. Health systems are also well poised to play a strategic part in fixing our food problems due to the proximity to communities and responsibility in treating chronic disease. So participation of value-based payment models that can incentivize patients' health-related social needs, such as food, needs to be more fully adopted. Cost of food for a year is much cheaper than an ER visit for health plans and systems. So not only does it make sense for patients, it also makes sense for the systems because of the return on investment. And we're seeing states across the country doing this. Take, for example, Mass Health, the Medicaid insurance product for low-income individuals in Massachusetts. They created one of the first programs to allow health systems to partner with social services organizations and provide nutritional interventions. This program is a $150 program, flexible service program, is being evaluated and is a model for other states to adopt as well. These interventions, like the nutritional food referrals, which provide vouchers for free or discounted nutrient-dense food, have made economic sense. The most intensive programs like medically tailored meals provide prepared meals tailored to patients' conditions. These medically tailored meals programs have reduced ED visits or emergency department visits by 70%, reduced inpatient hospital admissions by 50%, and reduced net healthcare costs by 14%. There are not many pills that have the same impact. Finally, we need to acknowledge the role of trauma, such as adverse childhood events and racism, have on food access and choice. We need to ensure that these interventions that address food insecurity and hunger also take on healing, social, emotional, and mental issues. So the US healthcare system and public assistance systems need a renewed, increased focus on health inequities, food insecurity, and chronic disease prevention. Public health policies and legislative initiatives that reduce food insecurity and food deserts in vulnerable communities also need to address the upstream determinants of health. The toll of COVID-19 cannot be undone, but we need to rise to the challenge of health inequity and unite in a vision for a more equitable, just, and fair nation. Thank you so much again for inviting me to participate in this panel. For more information about the work of Robert Johnson Foundation, please visit rwjf.org. Looking forward to answering questions. Thank you.